edition of the Antipsychotics Summer Health Series. And tonight we have another interesting topic that I think you will find helpful. Tonight it is another interesting topic that I think you will find helpful. It is a disease process that we have very prominent parameters not here in the U.S. but worldwide. And so we have a very capable ram in the bush tonight. We have little challenges tonight, but we are pushing through, and I think we will get something out of tonight. So before we start, we want to give honor to the shepherd of our household, Dr. Logan of the Antioch Church of God in Christ here, who has made it possible for us to do such activities as this. What we want to do is we want to start off with prayer, and we will get right into the meat of the matter tonight. So wherever you are, if you can bow your heads and pray with us. Oh, God, we thank you. We give you the honor. We give you glory. Give you praise. God, we thank you for another day, God, that you have blessed us to see. God, we thank you for the opportunities that you gave us even on today, God, to become more intimate with you and also to be a light and in salt, God, to someone that came across our path today. God, we just pray for those that are here. We pray for those who may be on their way, God, that you would bless and give them safe passage here tonight. God, we pray for the speaker and the speakers that will speak on tonight. God, we ask that you would open up their understanding. God, give them on what to say, how to say, and when to say. And we'll be careful, God, to give you the glory, the honor, and the praise. For it's in your Son, Jesus' name, that we pray. Amen. Amen. So tonight, as I said, we had a couple challenges. We had to shift a couple things, but we have someone that is capable tonight and someone that actually we all know, and that's none other than Dr. Angela Allen, who serves as the co-chair for the Antioch Health Ministry. So a lot of us know her, but maybe don't know exactly what she does. She does have a PhD, and one of her interests happens to be on dementia, Alzheimer's dementia in particular. And so what I would like to start off is to have her kind of introduce herself again from a professional manner and let us know exactly what she does in the field of dementia and talk a little bit about how she came to have interests in this field. So at this time, I'm going to ask her to, if she can first start off with, give us an introduction and tell us what you do and why you do what you do.
Thank you, Dr. Pullins. And so many of you all may know part of my job, as you can see on the slide here. I'm Associate Clinical Research Program Director for Banner University Medical Center of Phoenix, also for Tucson Hospital and Banner Alzheimer's and Banner Sun Health Research Institute. What I do is research particularly in various areas ranging from clinical trials to what we call investigational research. I have studies that range from babies all the way to older age, but my passion has always been in the older age population because I know ultimately we're all going to get there one day, prayerfully, and then also looking at particularly cognitive issues in the neurological area, specifically Alzheimer's disease and related dementias. So that's really my primary role, looking at dementias, at various dementias, not only Alzheimer's, but you'll find later there are other types, and how it impacts not only us as people, but also diverse populations as well.
So part two to that question, talk about the pathway, how you got to get involved in this particular field or this type of research.
Sure. So as I've mentioned, I've always been interested in geriatrics, which are older age population. And I never knew what I wanted to do in that particular area. I worked in a rehab setting, and I noticed that a lot of our older age population or people were not really getting the appropriate care or education as our younger people. And that was mainly because they weren't really grasping the information that was provided to them. I'll speed up the process and share with you that most people who go into research, whether it's cancer, COVID, or even Alzheimer's disease, they do it because they have a passion. There's something that may have impacted them personally. And as many of you all know, my grandmother was diagnosed with senility, or old person's disease. And that was as late as 2005, 2006. And so I said to her provider that I don't think that's what that's called. I think it's called something more than that. And so as I looked into it, and then, yes, I had to look into it, and I shared with the provider at that time, and this is someone in Michigan, I said, she may have some form of dementia. And the provider said, no, she's 91, she's getting old. And that's when I realized that I had to do more research. And because I loved my grandmother and still do, I realized that I had to be her advocate, and I had to do real research. And if the Lord would have it, as the Lord had it, actually during that time, I was offered a full scholarship for my PhD, but they had asked me to look for something that was different, and that was the only way I was going to get the funds. So I focused on discharge planning with medication, and they said, no, that's not good enough. And I moved on, and every time I focused on what they wanted, God was calling me back to Michigan to take care of my grandmother and to find out why they weren't diagnosing her with something more than that. And again, Lord was guiding my path, and my grandmother, as she's always stated she would. Long story short, I found out that Alzheimer's disease and related dementia in the older age population, particularly those of color and those who were in the long-term care.
Great, great. Speaking about Alzheimer's, can you tell us the impact that Alzheimer's, what does it look like here in the United States?
Sure. So if we move to our next slide, I'll give some statistics because I'm glad that we're starting off that way. If you'll notice that many of you we may not recognize because it is an older age population that is impacted, but it can be what we call early onset. Can happen at the age of 40 to 50 years of age, depending on that person. So 1 out of 3 seniors usually pretty much die from Alzheimer's disease or some other form of dementia, which I'll talk about in a moment. And we talked about just last week, breast cancer, prostate cancer, but many people don't know that age group, it kills them more than breast cancer and prostate cancer combined. That's how many people pretty much dies from some form of dementia. 6 million Americans are living with Alzheimer's disease. We don't know it because a lot of them are isolated. And by 2050, we're looking at doubling that, and that's just around the corner. When we also look at how much we're spending, over $320 billion is spent annually in Alzheimer's or some form of dementia. More than 11 million Americans provide unpaid care for people with Alzheimer's disease and some other form of dementia. In addition to that, I wanted to elaborate that about 16 billion hours are spent with caregivers providing care for their loved ones. And this is unpaid caregivers. And that's equate to $272 billion of those caregivers that are providing care. So typically, if you were to pay someone to do the same number of hours that they were doing, that's how much that would cost. In addition, 90% of our physicians say it's important to diagnose what we call MCI, mild cognitive impairment, and I'll talk about that in a moment, due to Alzheimer's disease, but over half say they are not fully comfortable in diagnosing. And when we talk about physicians, we're talking about our primary care providers. They may look at mild cognitive impairment, they may put a ticket on Alzheimer's disease or some form of dementia. And it's not because they're not capable, it's because it's time consuming. And I'll share a little bit more about that. Now, even though that's not on here, I'm going to share with you also about 17% of our patients died during an increase of 17%, of our patients died during the pandemic. A lot of it because they didn't get the appropriate care that they usually would receive during COVID, during the usual stance beyond COVID. So that's a little bit about our stats, and a lot of this information can be found in Alzheimer's disease Facts and Figures, 2021 and 22.
So you talked about the impact of disease of Alzheimer's, and so dementia, senility, Alzheimer's disease, a lot of those terms are used interchangeably by the public, and so it can be confusing as a layperson. Okay, what is dementia? What else Alzheimer's? What does it mean to be senile? Because a lot of times you saw, particularly in African American culture, is when people get older and they start forgetting, they'll just say, oh, they're just senile. So can you talk a little bit initially, what is dementia to begin with? Absolutely. And what's the difference between that, Alzheimer's, senility, those
Absolutely.
kind of things?
So as you can see on the slide, dementia is not a disease. And I've shared that with many people. It's more of an umbrella that characterizes what the disease is that I'll be sharing with you in a moment. it actually impacts the person's daily function. And that's really how they're diagnosed. It's not because they would, as Dr. Pullins pointed out earlier in our series, know your numbers. So it's really not a know your number game. It's more of a, do you know the person that you're caring for, with, living with, spouse, family member, mother, father, and do you know that they're acting slightly different? So that's what we're really looking for, which actually impacts their daily life. Some of the things that you'll see is language. When you talk about language, I'm not saying the type of language that they speak, such as English, et cetera. I'm talking about speaking in a way, for instance, I have been often told that I'm a little bit articulate, so I may speak or share certain things. But when my speech becomes different and I'm not utilizing 3 to 4 syllable words, or if I'm trying to pause or I'm causing a pause, if you will, and I'm not figuring out what's going on, it's a delayed response, then you'll notice there's a concern. Another part of that language is what they receive. So oftentimes you may not hear what they're saying, but you may probably kind of what they're receiving. So for instance, let's say we're in church and a church member who's often sitting up front, they're getting the message, they hear everything pastor says, and at the end of the service, you walk up to the church member and you say, did you enjoy that service? Did you remember when pastor says this and the other? And they say, I don't remember half of the things he shared. Again, that's not what they're saying, but it's what they're receiving. So again, that's that language. When we look at executive function, that's that decision making. That's really where the judgmental area, where they really, let's say a family member, a loved one balances their checkbook, or for this matter, we look at electronically balancing certain things. You'll see that they act different or not doing it in an appropriate way. Visual spatial, I call them every time I see this, I call them my driver fears, if you will. These are people who truly, and this is just an example, who are driving, but they're not really spacing themselves. I don't want to categorize a particular area in Arizona, but you may see them on the road and they're driving too close to you, or they're moving over to the side. They're not visually, spatially adapt to what's going on in the area. Their mood, their behavior, their personality is totally changed. And oftentimes that can be actually identified as someone who's just getting old. And we have to stop saying that, because this is not a normal part of aging. If a person's behavior changed, and I mean change within a matter of a month or so, there's a concern. And that's what happened with my grandmother. They realized that she was acting slightly different than she's done before. Reasoning and judgment has been pointed out. And then also gait and motor function. When we look at Parkinson's disease, which is a form of dementia, you'll see that the person is not walking right, and their gait is shifted and more shuffling. And that's when you recognize there's something wrong with that person. Oftentimes they have been assessed to see if there's any degeneration in their bones, joints, or some arthritic issues, and they find out there is, and it's because of the brain is telling them how to walk in an inappropriate way. So these are certain things that you'll see with dementia. Again, there are various types. So if we go to the next slide. So dementia versus Alzheimer's versus MCI, mild cognitive impairment. And again, we say these words interchangeably, but Dr. Pullins pointed out earlier, senility. One of the things I want to share with you is we want to get out of that word senility. We also want to get out of that word dementia. And the reason you may say, well, why? Because when you see a specific disease, you treat that specific disease. When you consider a person senile or senility, which often is come in the psychiatric area, or when you see them in a dementia, you don't really know how to treat them. But when you name that dementia, you can then begin to treat them in a way in which you're supposed to. So give you an example, dementia. It describes symptoms of progression in the cognitive and functional decline. So this is something that occurs, it progresses. It may not happen overnight. It may happen for years. I have some of my patients who have actually still in the same stage. And then overnight, I've had some of them that the loved ones have called and said, hey, my husband is really off. He's not doing the things. And I say, yeah, because he's going into that next stage. So there are over 100 causes of dementia. And oftentimes we say, well, how is that so? Well, not to go back to that previous slide, but if you look at that previous slide, all of those areas, they don't occur concurrently. They occur in stages. So you may have short-term memory loss and you're mild, but when you get to your middle stage, you may have some type of movement disorder. So it's actually over time, you'll see the progression of these diseases. For Alzheimer's disease, the reason why we say those interchangeably, Alzheimer's and dementia, is because 60 to 80% of patients who have been diagnosed with some form of dementia usually it comes up to be Alzheimer's disease. It's the most common type, as mentioned. It's the progressive degeneration of the brain cells that is caused by abnormal protein buildup and disruption of the brain connection, which you'll be seeing in a moment. Other causes and other types, and these are the very common types, but again, there are over 100 types. Vascular dementia, Lewy body and frontal temporal dementia, degeneration. So what vascular dementia, and I wanted to make sure that one was first, is that over 54% of patients who have had some type of stroke usually have some type of vascular dementia. I worked in a rehab setting, and I worked on a stroke unit. I actually was the manager on that stroke unit. And I can remember seeing some of my stroke patients coming back within a month. And I would say, hey, Mr. Such and Such, hate to say I'm happy to see you, but hi, how are you? And they would not remember anything that went on in the previous rehab stay. We weren't at that time, and this was back in the early 2000s, late 1990, we weren't even diagnosing them with all vascular dementia because all we saw was the stroke, but didn't recognize that the degeneration of their brain cells were occurring, which they were actually should have been diagnosed with some type of vascular dementia, which at that time, they would have been treated for it, which I'll talk about the treatment in the medicinal approach. And then our mild cognitive impairment, and I don't want people to get so twisted up on that term. Mild cognitive impairment is a condition in which people have memory or other thinking problems greater than the normal age or educational level. Now, what happens, about 1/3 of the people living with MCI or mild cognitive impairment due to Alzheimer's disease may develop some type of Alzheimer's or dementia within the 5 years, but not all. There are people who have been diagnosed with MCI and live for the rest of their life. It doesn't really impact their independence, but it allows them to understand that I'm diagnosed with MCI. I now have to find ways to cope, whether it's Post-it notes, whether it's a map that I always have to put in my car just to get back home or to go to the store that I always go to. It's just the coping strategies and mechanisms that they use.
So that's good information. You talked earlier, and when you talked about Alzheimer, about abnormal protein buildup, disruption of connections. Can you go a little bit more detail to what's actually going on in the brain with people with this disease?
Yes. So if you'll notice on this slide, it does look a little dangerous and complicated, but it isn't. This is what's in our brain. So we have neurons, and those neurons are basically our brain cells. And those neurons or brain cells really have what we call neurotransmitters. Those neurotransmitters are what we have that causes or delivers communication. So even when you get up right now to go to the restroom or go to the back to do something, or if you look at this slide, your neurotransmitters are actually communicating with each other, sending messages to tell you to look this way or to get up, to walk, etc. And believe it or not, I think Dr. Pullen said something that was amazing on our first session. I do listen. He says, it's amazing how we wake up every morning and our body works. And because my specialty has always been in neuro, when he said that, I immediately thought of this slide. Our neurotransmitters are communicating, it's telling us what to do, and is basically obviously regulating in a way. Now, just imagine if you had these neurotransmitters and all of a sudden you're diagnosed with some form of dementia, Alzheimer's disease, if you will. What happens is there's a buildup of what we call amyloid plaques, and it's amyloid beta plaques, and you'll see later on the slide it says AB, and tangles. And I'll say it more in a layman's term. They're called roadblocks when I speak to my community. And what happens is, if you notice these neurotransmitters are communicating and telling us what to do, just imagine, I'm sure many of us have run into roadblocks and we've detoured in another way. What happens is those neurotransmitters have to stop because the Alzheimer's disease, the buildup of what we call amyloid plaques and tangles have caused them to stop. So again, you have a patient who has moderate stage of Alzheimer's disease, and I'll go into moderate because it's a little bit more detailed, or a loved one that you've noticed, and all of a sudden they're sitting there and you say, come on, get up and let's go to the restroom, or let's go to bed, or we're getting ready to go to the store. What happens is the neurotransmitters, when they send a message to say, I get up, to get my legs up and I walk to the store, it's blocked. They can't do it. So what happens is the person with Alzheimer's disease or some form of dementia is just sitting there because they can't figure out what would make me get up to walk to go to the back of the room, to go to the store, they can't. So that's when you see it in a pathological way, you'll recognize, wow, I didn't realize that that's why they're doing it. It's not because they're doing it intentionally, it's because of the brain cells. We also have what is called acetylcholines. Acetylcholines and glutamates are actually chemicals in the brain that actually helps the memory. It really allows the memory to make sure that it's telling that person, remember when she said get up before? You get up and you go to the bed. Well, the acetylcholine and that glutamate has been disrupted or is broken down. So unfortunately, it won't occur because the Alzheimer's disease is not only causing the roadblock, but it's also killing those brain cells and causing that person to lose memory. And you'll see that in the future slide. You go to the next slide. So here's the future slide. So when we look at these, here's a couple of things that we'll look at, the neurons. So if you notice on the ones area, it says normal brain cells. That's how our neurons should look in our normal brain. We basically have the brain cells, neurons, again, thousands and thousands of them, neurotransmitters, they're communicating with each other. But when we see a person who has some type of Alzheimer's disease, we see the buildup of plaques and tangles. Now, don't get me wrong, amyloid plaques and tangles are normal. We all have them. We have them and we've had them, and you'll see in the next slide, it pretty much grows and actually formulates. But the concern here is that they build up, and this particular person may have too much. And so that caused the blockage. And again, there's where you see the amyloid plaques, or AB, amyloid beta plaques, and also the neurofibrillary tangles. The other portion is I want you to look at the images. So sometimes, and I'll talk about that in a moment, there are different ways in which we detect whether a person has some form of Alzheimer's disease or dementia. We do it first by actually, you come into the office and we have what is called an annual wellness visit. We ask all the patients that are 65 years of age and older, typically they'll have that visit. They've been asked questions, or it could be a loved one who may share with them that my mom, or in my case, it was my grandmother. My grandmother isn't acting the same. I need you to do an assessment. And here's where what Dr. Pullins pointed out in his first presentation as well. We have to be advocates for our loved ones. We have to be that person who's the liaison to be able to communicate with the providers, because sometimes they may not, even their spouses. So you may have an older mom and older age mother and father, and you may have to step up and say, hey, I need to speak for them. So again, you're walking into the office and they'll say, okay, let's do an assessment. The assessment begins primarily with a couple of things. They do an MMSE, which is a mini mental status examination, or MOCA, which is a very short version of that. And then what they'll do is just kind of determine whether you've failed or passed. Basically, it's a written test. The other thing that they'll do is they will draw blood. Now, I know you're wondering, wait a minute, I didn't think we can draw blood. Well, what they're doing is what we call rule out. We have urine, we draw blood, we determine whether that patient has any other type of disease before we pinpoint them and stamp them with some type of memory problem. So when we rule that out and we realize they do not, then we move to the next stage. If they fail the test, if they don't have any of those things, then we do what was called a workup. And that workup is basically the scans. We have a couple of scans. We have the CT scan, which is the CAT scan, a computerized tomography scan, or we have the MRI. Now, the MRI is what we call the standardized scan. That's the gold standard when we detect. And what happens is what we're doing is we see these images here. In this first image, we see a normal, older age individual. Hopefully, this is what we would all look like as we get older, those blue areas with the tau and the amyloids. And again, we may have some amyloid and tau. That's the normal part of how our brain functions. But when we see then we see a normal, older age and a high amyloid and tau. And what that means is the person may have, again, some buildup of amyloid and tau, a little bit unusual growth than a normal age. You may end up having a person that have what is called MCI, as I mentioned earlier, a little forgetfulness, because remember, the amyloid and the tau is blocking memory. And so it's not blocking it to the point where they can't function, it blocks it to the point where they have to strategize and figure out what other ways to do. And then we have the Alzheimer's disease, which is the high amyloid and plaque. And you'll see that little grid on the side is called a legend, where it kind of tells you there's some red lights. And so when you have a neurologist, and oftentimes it's the neurologist who's looking at these scans, he will or she will say, wait a minute, there's some brick red lights, we need to really do some further workup. And then that's when we're doing further workup. But typically we'll see that that person may have some form of Alzheimer's or some form of related dementia at that point. And then we have the slide over here, which is that little picture. Now, I work in a setting, believe it or not, my office is around the corner from thousands of brains. And so in that refrigerated area, this is what we see. We basically have actually Banner Sun Health Research Institute is one of the largest brain banks. We have one of, there's several others in the country, but we have brains that we actually have after autopsy. We may have normal sized brains because we're doing where maybe a family member had a history of, and other family members. And then we also have patients who have had Alzheimer's. So that is what you see on the right side. My right side is the Alzheimer's brain. It's shrunk because what happens is those brain cells have died. And so that's what we're depicting there. So it kind of gives you an idea from the pathophysiology, we look at the imaging, and then we look at an actual brain and what it looks like upon autopsy. So we go to the next slide, and I like this slide. If we can click it, and I hope it works. Click it again. See what happens. Oh, nope, go back. This slide, there's a little image on the bottom, and if it doesn't, don't worry. What this image does, it's scary. I'm gonna go there. And the reason why it's scary, because what you don't see at the bottom is, that's age, that's an actual age, 20 years old. And it goes from 20 to 55. And what that does is, if that little bulb actually moved, it would actually show two images. On my right side, that image would actually be predominantly blue. That means that's what a normal brain looks like. But on my left side, that would be blue and red and yellow or whatever. That's what an abnormal brain would look like. And what this is telling you is that a person who has unfortunate potential of having some form of dementia, at the age of 20, those plaques and tangles are developing. And then they grow and grow, and they grow so fast that their brain on this side turns a certain color, which is what the imaging says. But a brain on that side may just be blue. And so that's how early it starts. It doesn't start at the 50 and 60, what we think. It starts early. It's just that it builds up, and it grows much faster than typically it should. And so again, that's really what that image would depict.
So there's a question that I'll come later, but you may not have on a slide. But when you see those kind of slides, I think one of the first questions that come up is maybe prevention, and is there something that I could be doing now to prevent that, knowing that, if I'm at 40, most likely I already have some tangles in my brain.
And I will be speaking about that later, but I think before we get to that slide, let's go back to the previous slide, because I don't want everyone to look at those medications until that's a good question. So first and foremost, many people know I'm very transparent. I think I have to be that way as a healthcare professional, because if I'm not, then I'm kidding myself and lying to you. As I've mentioned, my grandmother, who's my father's mother, has some form of dementia. My mother's father's sister had some form of dementia. Pretty much all my father's, his mother, his aunt, his grandmother, all of them had some form of dementia. So do you know where I'm going with this? Women in my family had some form of dementia, not as much on my mother's side, but on my father's side. So I'm cautious. I have to be mindful of what's going on. Proactive, preventive medicine, and I'll talk about that later. But what I do is I say, what can I do to try to decrease my ability of getting some form of dementia? Remember, there isn't a cure, so therefore I can't prevent it. But I have found that most of our patients are now, because they've been educated, they are coming in at the age of 90. I have a couple of 100-year-old centrillions. They're walking in now with some cognitive impairment, and because they still want the quality of life as well. So what my hopes are is that what we do is we try to delay the progression of the disease, but not until we have a cure. And I hope I'm living at that time, but not prevent it. So those are things, and I'll talk about those.
So treatment may be kind of a misnomer, but can you talk about what's available now on the market for patients who have dementia? And the next question is, do they help?
Yes. So we go to the next slide. So available Alzheimer's treatments, and Before we get to the slide, yes, I am going to read this cartoon because I thought it was interesting. It says, look, you've got to stop thinking that one little pill is going to resolve all your problems. You need to take at least 4 twice a day. And even though that's a cartoon, I want to kind of go off the subject for a minute. I talk to patients about that with COVID. We can't just take one little vitamin and think that's okay. We still have to get our booster. It's a commercial break. We still have to get our booster. We still have to take all of those beautiful vitamins so that we can build up our immune system. So that's the same thing with Alzheimer's. So I want to.
If I can add on to the commercial
Yes.
break. So Dr. Poland told us about 2 or 3 weeks ago that there was going to be a rise in COVID. And what are we seeing?
Rise.
It's happening among us. And because we are not monitoring, because states have basically stopped monitoring and people are testing at home, we really don't know what the numbers are, but obvious that what he's saying is we're seeing it right in front of our eyes. So I just commercial break to listen, wear your mask, get your vaccines.
And take your vitamins and drink
Yes.
plenty of fluid. So those are things that again, thank you for the commercial break. So so let's talk a little bit about medications. And if you don't mind, if you have someone that has some form of dementia, I think it's so important that you write this down because it's important to know these. So some of the medications you'll see are cholinesterase inhibitors. And what those cholinesterase inhibitors do, they actually help that acetylcholine that I share with you that helps with the memory. And that's what we want it to do. We don't have a cure, but we try to say, if we know the acetylcholine is the one chemical in the brain and the glutamate that helps the memory, then we need to find a drug that's going to help that. And so therefore it's blocking all of that bad thing so that those 2 chemicals can work. So the most common type, and Dr. Pullins may be familiar with this, is Donepezil or Aricept. That is basically a drug that is used to help prevent the breakdown of chemical acetylcholine. We have actually shared with our providers, our family practice physicians, that, it's okay if you find a family member or a patient who's coming in and they say, I'm having memory issues, and you're doing a little workup. And even if you do the assessment, you ask the questions, you do the rule out, it's okay to start them on with Aricept because that's the first drug that we typically try. That is a major issue with that is GI problems. But I always tell people, do you want to remember that you had some issues with your GI, or do you want to just, not have, So the bottom line is that we encourage you to do Aricept and Donepezil until we do a full workup. And the full workup typically from our office is usually having them go and visit a neuropsych physician, and they actually have 6 hours of full workup.
Quick question. So you said you have them go ahead and start it. So until they get to you and do neuropsych testing. So I would assume, and I may be incorrect, that would you have them stop the medication before you do your baseline testing? Because I would wonder if that medication would give you a false read on your neuropsych testing.
Yeah, so it depends on the provider. And even tonight, I was speaking to the provider that was going to be here, and she actually talked about that. She said it depends on the specialist, if you will. So she's a double board and neurologist, psychiatrist, and she says she does pause those medications, and then she does her whole workup, especially if it's something that's going to cause a false reading. So you are correct. But there, again, providers, we tell them, because we, believe it or not, we have actually had, I don't know if we are doing it now, but we've had patients that were 3 months out. And so we don't want to just have them just waiting and not have any medications at all. So that's a good question. So the next one is rivacetamine, and that's an Exelon. That is actually a medication that we usually give as a patch. That's also, by the way, the first one is during the mild stage of some form of dementia. Again, we ask that you come in as soon as possible when you think you have some cognitive issues, that we hope to place you in the mild stage. The second one, as I mentioned, is the Exelon patch. That prevents the breakdown of chemical acetylcholine and also increases the level of the brain cells. Oftentimes, I used to tell my family members, and one of my doctors said, no, not really, but you can say that. Because a lot of patients choose not to take a pill, they're agitated, they're angry, they're asking, they don't want to. We will probably try to encourage them to take the patch because it doesn't do any of the GI issues, and then also it's placed on and rotated or removed and placed on every 24 hours. So that's actually one medication that we try. The Galatanamine, which is Dirazidine, that's another medication. Again, that's given often in the mild stage. That's same as the others. It actually prevents the breakdown of the chemical acetylcholine as well as increase the levels of the neurotransmitters. Because again, you want to make sure that you encourage or increase that communication. That's the whole thing. It basically, if you want to say in layman's term, it removes those. It doesn't remove them, but it pushes the roadblocks so that they can go around them, because there's still going to be some type of roadblocks or barriers for those individuals. Nemantine or Namenda, remember I shared with you that's the acetylcholine that actually causes or helps with the memory. Also, glutamate is another one that helps with memory. It enhances the memory. Typically, Namenda or memantine is given during the moderate stage, because this is when we notice that gluconate pops up. And so we actually start them. A doctor may start the patient on Aricept or one of those 3 meds at the beginning, and then they add Nemantine. They don't just remove the Aricept. So they will add that medication along with the Aricept or those other medications that are there. So the next medication is Nemzeric. You may have even heard commercials of Nemzeric. Nemzeric actually operates just like an Aricept and Namenda put together. A couple things about Nemzeric. Nemzeric, because it was fairly new, some of the providers may not have actually given it because they were curious whether it would cause issues or major side effects with the combination of the two. Also, insurance was questionable about whether we should get it. I remember when we were offering it, one of the patients said, my insurance doesn't really offer this medication or pay for it, so we had to pause, and the patient would take 2. But we try to encourage Nemzeric if we can, again, a combination of the 2. And Adalimumab, I always mess that up when I'm talking in the clinic as well. That's a new medication that has been offered. Now, this is always this question we used to ask, I think don't go to the next slide, but we talk about what are some of the treatments that occurred, and we haven't had new treatments in years. Well, this is a new medication that started in June of 2021. And this medication has actually been to eliminate the clumps of the toxins of the proteins that I talked about. So it's almost like it dissolves those proteins so that basically the neurotransmitters can actually operate. It has been very effective. I noticed that a large percentage of African Americans people have actually recognized it as been effective as well. So that may be something that it will be up and coming, and again, we'll spend more time. I think that's also a medication that's questionable with insurance, but you know, when you have been treating somebody with a certain medication for a long period of time and insurance sees that it has operated and worked, they're going to obviously pay for it. But when they have to see and do the trial and error, et cetera, to find out if those medications work. But they're all FDA approved, so I don't want to say that they're not. That's what you're going to ask. I knew you were. I can read your mind. So the next one is, this little picture here, this is why it's here. Oh, is that all I have to take? Is just those medications, the cholinesterase inhibitors? No. A lot of people don't realize that patients with some form of dementia, they also have other issues. Not just the fact that their brain cells are dying and they're not having good communication with neurotransmitters, but they also have behavior issues. And that's something we have to really think about. We have what is SSRIs, RI. These basically are medications that are treating patients based on the behavior. Citalopram, which is what we call our standard medication that's used for multiple things, antidepressants, antipsychotic medications. You've probably even seen them in youth. But these medications, Zoloft, Remeron, Trazodone, all these medications are identified as antidepressants because patients with some form of dementia, they're not always upbeat. There's obviously going to be some concerns, and we actually have diagnosed most with clinical depression based on that. So we do medicate them accordingly. And I can tell you a large percentage of our patients have been, their medications were changed when they were in support groups, believe it or not, because there's a support group, a family member saying my husband's not wanting to get out of bed, blah, 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 because she feels very comfortable sharing that. Most of our support groups are offered by clinicians. So here you have this clinician hearing this, and then they will then follow up on it and find out that the medication that he is taking is not been effective. So they increase the medications and help with that antidepressant. The Suvorexant is actually a new medication for insomnia because we noticed that a lot of our patients, you ever heard of sundowners, patients with some form of dementia, walking all at night and doing different things. So we do have medications for that, and that's fairly new as well. Quintanapine, which is Seroquel. Many of you all are familiar with that. Risperdal. These are our used for bipolar and psychotic. So again, we have patients who have gone through cognitive issues and have changed their behavior. Again, I speak of my family member. My grandmother, I didn't know, and she never had a history of any of these things, but when I would walk in the room, I didn't know if she was going to be one person or the next. So, of course, when they said, Angela, I'm sorry, we're going to have to put your grandmother on Seroquel, I said, do it. Because if it's going to stabilize her behavior, then I need her to be functioning to the highest quality level as possible, despite the fact that she's getting medications. They work. And I'll put a plug in, and I say this because we as people of color often say, when we look at these medications, but we don't say, when we take Tylenol. We don't say, when we take our lisinopril for our blood pressure. So why would we say, when we're looking at these medications? They're helping us stabilize our mental state.
Yeah, I was going to just add a couple clinical points because being in primary care, I deal with dementia patients all the time. And so I also see the effect it has on families and nursing homes or where these patients are at. And so one thing that's interesting is that when you talked about dementia, and you said there's over 100 causes of dementia, depression is one of the only reversible types of dementia. So meaning that somebody who's very depressed can actually present with dementia presentation, but they don't have dementia, it's actually depression. That was one thing. And then the other thing is those last medications, those antipsychotics, and you talked about the sundowning, and when patients start to hallucinate and sometimes they get violent, you get calls from patients, their family members in particular, they have no clue what to do. And so these are some of the medications that we use in those situations. Now, there's a little caveat with that because there's something called the Beers criteria, which means that there are medications, if you're over age 65, that there's a list of medications that are considered unsafe or potentially cause problems. And so most of these antipsychotics are listed on the Beers criteria, and most patients who have Alzheimer's are over age 65. So what do you do? So it's always a balancing act to figure out how do you help the quality of life of that patient and their family and to do no harm at the same time.
That's a good point. Thank you. So we go to the next slide. So people have often asked, well, do they really work? Well, like all medications, they have trial and errors. And what we've detected is that when we see patients and you'll look at the little line on the side, that's the function. It should say function. And at the bottom is time. So when you look at the red line, you'll see Alzheimer's or related dementia patients who don't take any medications. So therefore, their mild state, you'll notice that they have a less time of functioning independently or appropriately, if you will. And then the next line is the cholinesterase inhibitors, which are your Aricept and your Exelon, those medications I shared that usually is given during the mild state. It allows the person to function and have a little more time or quality of life. And then the last one is your Alzheimer's with cholinesterase and also your Namenda, which is that medication I said is usually given during the moderate state. Again, it gives that person a little bit more time. And so I wanted to put that there because we noticed that it's been proven that these medications are effective. It just gives that person a little bit more time. As I shared, my grandmother was diagnosed at 91. And I said, no, you're going to put her on all medications. Unfortunately, she was only on one of them, but she was able to live 6.5 years with a form of dementia because of the treatments that we've provided. I'll keep going because I know of time. Next slide. So people ask, well, do I always have to take medications? Or do I have to take them even during the time I'm not, possibly I'm thinking, like Dr. Pullen said, I'm diagnosed or possibly diagnosed with some type of memory problem, but not truly diagnosed based on my provider. Well, there are things you do, memory training, mental and social stimulation, physical exercise programs, and the list goes on. And I think the most important thing in this list is do what you like doing. If you like listening to music, listen to it. I love reading books. If you go to my house, I have a whole whole library, and I probably read all of them, because to me, that's what continues to stimulate my brain. So the main thing is just keep, that isolation. When I talk about the increase of 17% of our patients with some form of dementia die, is because the lack of physical and mental social activity was really a huge issue for them. And so these are things that I wanted to just plug in to just say, yes, we still want our brain to function, if you will. Next slide. This is a question, hope on the rise and advances in Alzheimer's diagnosis and treatment. Go to the next slide, please. So the answer's there, darn it. But anyway, it didn't work. So no, you don't, even though I'm around the corner from 1,000 brains in a freezer. Does that mean that that's the only way that we can actually truly accurately diagnose someone? No, there are ways in which we can diagnose them during and pre, just to give you an idea. Next slide. So we can diagnose accurately during life with brain scans, spinal fluid, lumbar function. Actually, my colleague, Dr. Danielle Goldfarb, the person I shared with you that was here tonight, she is the person who leads our spinal fluid and lumbar puncture assessments. Blood tests. You say, wait a minute, I thought it wasn't. Yeah, there aren't any ways in which you can identify, but there are ways in which they're finding that when they do blood tests, they find a buildup the amyloid and plaques in your blood. And so that's new tests that they're doing now. And that's great, because I love the fact that we're able to recognize it. We can even diagnose Alzheimer's patients before memory loss begins. And that's something important. That's that screen that I share with you. If they went up, you'll see that. Next slide. So here are all of the pictures that I shared. Here's your MRI and what it looks like. There's the axocoronal and the sagittal view. Again, it's this way they're cutting the brain, this way they're cutting the brain, and this way. So again, you're seeing all of the ways in which they cut the brain. The PET scan is fairly, it's not new, but it's commonly used. It's actually been done. We do treatments or clinical trials, and a lot of people don't know this, Dr. Pullins, that clinical trials, if you sign up, a lot of this stuff is free. You don't even have your insurance, it's not paid, because you're doing them a favor. They're not drawing blood or giving you anything. They're just trying to detect whether African Americans or other types of individuals are actually having the same effect, if you would, in any other form. And I think that's phenomenal. Yeah, I am involved in a couple of clinical trials because I want to be that person who saves my next generation, if you will. We have the blood biomarkers. They're not giving blood, they're taking blood so that they can determine the impact. And then the spinal cord, which actually I share with you, they determine the amyloid buildup and plaques inside of the spinal cord area. So that's what these areas are, just to give you an idea of what they're doing and determine the biomarkers. Next slide. So again, the biomarkers basically just determine whether, and I'll go through this one really fast, it just determine whether baseline, whether that individual, and if you go to the next slide, you'll see it, whether that individual actually have this problem, if you will. So if, again, it's the minimum, the maximum, over time, whether the person is progressing in some form of dementia, and all of those tests will determine that. And so that's what these biomarker abnormalities will detect in that area. So just kind of giving you a depiction of that. If you go to the next slide. So advances in treatments. This is a slide that I was sharing with you. Between 2003 and 2021, there was nothing. We had thousands and thousands, and I say thousands, but 200, but there were other investigational studies that were going on that failed, that didn't work, and then people just said, forget it, we're no longer going to do anything, even though they were paid for them. That was okay, because that's what happens in research. You don't always expect to have a outcome. But then in 2021, we have the Duhem medication that was actually offered. I shared with you what that did, so it broke down that amyloid plaque, and that's what's here. But in April of 2022, Medicare decision is not to reimburse due to limited evidence of meaningful effect. And that's what I was sharing with you. Medications, even though they're on and available, you may say, I want that medication Dr. Allen talked about. Well, again, it's CMS. They have to know that it's going to work. And so over time, they'll eventually say yes or no. And so that was one of the plugins I wanted to throw in there. I know we have a person that's coming in, but I want to go to the next slide to make sure okay. So what is the number one concern when it comes to Alzheimer's research? And this is another slide that you weren't supposed to see, but a lot of people think the number one concern is money. There are thousands and thousands of dollars. I'm a big component when it comes to grants. I'll write something in a minute just to get a few dollars. And so I've written grants. Myself and Dr. Danielle Goldfarb, we just received, I think it was like $250,000 for a grant. And the reason why she did it, she said, put your name on it and I can get the money. I said, okay. And what it was is my name on it because I'm African American. And she knew the population that I service. And so with that, we were able to get the money. But it's the money isn't the problem. It's the first one, the lack of volunteer participation.
I just want to be clear, because when people hear these big dollar amounts, they think, oh, you load in your pockets. But research is very expensive. And so to have a coordinator and all different people you have to get done, that money goes quick. So $250,000 sounds like a lot of money, but it's really not that much, particularly if you're trying to do a reasonable study that's going to make a change in the literature.
And I want to put a plug in, as Dr. Pullen knows, I work full-time, so I can't get any of the money. It's a conflict of interest. I'm just happy to get it out there and make sure that it works. So that is a big important thing. Sometimes too late in the disease, people come in and say, oh, I want to get involved. And you know why we want to get involved? Because our family member has progressed so much that they're at the advanced stage, and we can't do it. We want you when you're at mild stage so we can find out what's going on. Inappropriate drug dosages and type of study and design analysis, and that's on the investigational research end. It's not on your end. So this depiction, as you can see, is the lack of diversity in clinical trials. We don't have a large percentage of African Americans that have been involved in clinical trials, and I'm going to put that plug in again. It is not them giving you something, it's them getting something from you to see what's happening, to see if we're treating you the same way we would treat anyone else. So those are major issues there. I'll go to the next slide. I want to make sure. Okay. So in 2021 and 2022, if you look at Alzheimer's disease facts and figures, and it's actually a book that comes out every year and they change. In 2021, they focused on health equity, African Americans, diversity. And 2022, they're focusing on mild cognitive impairment because they're finding that there's a large percentage of mild cognitive impairment people, which I shared with you earlier, that are not being treated. Some of our providers may say you have mild cognitive impairment, and what they'll do, you guys will do, you'll say, hey, go get a workup. But you've given them the great medication and you've shared with them, you're okay now, but go get the workup. They don't go to get the workup because you said they're okay. So we are finding large percentage of our MCIs coming in at a moderate stage of dementia when they should have come in when Dr. Pullen said, go get your workup. And that's so important. So basically we have to better understand racial and ethnic attitudes. We need to be able to be more diverse in our areas. We need to look at different populations and also ask about access to care support. There's so much money out there, trust in providers, and also participation in clinical trials research, and also caregiver respite. A lot of our caregivers, especially in the African American community, we think we can take care of our own and we don't need the help. I don't know. Come on now, the money's there. Go get the respite. Respite is nothing but you have a break. Someone's going to come in here and take care of your loved one, or have them go to a facility. With my grandmother, we have what was called a PAC program, and so they would pick her up, take her to the facility. She would fight, but that's okay. And then she would be there all day, just like a child. She would be there all day and get settled in, and then she would come back home and fight again, but it was okay because we had a break. That's important. So this next slide, I want to make sure. Okay, so here's some of the findings, and I think this is very important. When we look at it, some of the findings in 2021, and as I shared with you, that was the Alzheimer's Fact and Figures whole platform. Dementia risk in African Americans is 2 times greater than their non-Hispanic whites, and in the Hispanic population is 1.5. Half of the African Americans, 50%, report that they experienced discrimination when seeking health care. More than 4 out of 10 Native Americans and 1/3 of Asian Americans and Hispanics likewise reported experience that with discrimination. So we immediately walk in and say we're going to be discriminated, but we also have to recognize that we can actually get the same care as anyone else. We just have to know how to navigate around it. Concerns about developing Alzheimer's is lower among Native Americans, Blacks about 35%, and then of course 41%. And what that says is that we're not that worried that we're going to get it. And I'm going to say this, look at our white counterparts, about 48% are very concerned. And so if we know that we're 2 times greater to get Alzheimer's than our white counterparts, but we're less concerned, that's a concern. That's a problem right now for me, especially in my field. I actually say, if you got it, Dr. Pullins and I often say this 100 times, HIPAA, HIPAA, HIPAA. When you share something with us, it is with us. It doesn't go outside of our communication or our space. And so if you have that concern, please say something. 1 in 5, 21% of African Americans and 20% of Hispanics say they will feel insulted if a doctor suggests a cognitive assessment. Didn't I say that earlier? You know, why? Would you be insulted if you have hypertension? Would you be insulted if they say you have diabetes? You shouldn't be insulted if they say you have a cognitive issue. Get treated. And then over half of our African Americans, 53%, trust a future cure of Alzheimer's disease will be shared equally, regardless of race, color, and ethnicity. And so again, we're hoping that is true. Next slide. So here's something that, again, you could look into it later. This is a session that we did with First Institutional Baptist Church. Many of you are. We actually advertised this, and I think Deacon Robinson provided this information on the Thursdays when they were doing it. We talked about what is dementia. Dr. Morley, I did understanding behaviors in dementia stories. We had caregivers. We had essential planning, and we had a person who's renowned, for Dr. Epps, who's renowned throughout the country. She spoke on cultural realities, and then we also had a concluding series, if you will, as well. So we pretty much gave this information, and this still is out there, so that's one of the reasons why we wanted to make sure we shared this with you. Next slide. And I'm not going to go in detail with these slides, but I just want to share with you that picture before is basically the reason why we did it. We wanted to make sure that we have equal access to all of the material and all of the resources that are being provided. I can tell you, Dr. Pullins, working in my area with dementia, I probably can count, just like I do when I'm at Arizona State University, I can count the number of people of color, particularly African Americans, in support groups. And we shouldn't have that. I should not have to count them. I should be able to see that there's just as many as any other culture. Connecting and matching resources, and also creating delivered and engaged team members to be able to address those concerns with caregivers. Next slide. Here's this series. When we did it, we had over 300 attendees. We 45 views, 20 to 30% completed the survey. 85% were identified as African American, 80% were female. So we have a lot of our caregiver females that are actually always wanting to know more. And here's our breakdown in the age range of who was there. So obviously we had about 5% of our participants were 31 to 50. And we found out that 5% were grandchildren or children who had loved ones that had some form of dementia. But again, we want to be proactive, and we want to be able to share with our children, our grandchildren, to be in these programs so that if something should happen, I would like to know what it is and what they need to do. Next slide. So again, one thing that I want to plug in, and Dr. Goldfarb wanted me to share this as a plug-in. The program that I talked about, Dr. Pullins, that was $250,000. He's right. We get none of the money. But what we do is we develop jobs. And so here's a job here, Banner Alzheimer's Equity Nurse Navigator. She wanted me, and if you have a picture, you have someone who's a nurse who's interested in a position, it does pay a very nice fee, but this job actually is what she's created is a nurse navigator for the African American community. Because what we found in our research that a large percentage of our African Americans do not want to talk to people who don't look like them. So this navigator is she's seeking someone of color who is able to talk to these individuals and share with them. And I'm not saying it's like me, because I do that, but let's just say imagine me being in that position. And me sharing with you that I understand our culture, our ethnicity, and I understand what we're going through, and this is what we're going to do to help. So we are seeking a person for this position. If you know someone who is a nurse who may be interested in that position, and I'll give more information at a later time if you're interested. We'll move to next slide. So the next slide, basically a program that we did was called Dementia, and it was more on the grief and loss stance. It's a program that was identified as ambiguous loss, and that term is going to be shared in one moment. On June the 9th, I did this workshop because I wanted to find out if this workshop was culturally appropriate for African Americans. So it's about 7 people that want to call, and some of the things that we talked about was what is ambiguous loss, how did it impact us, and the outcome is we found very similar to the presentation slide I shared earlier. Access to care and support services was some of the concern, trust in providers in the healthcare system, and also participation in clinical trials, because they didn't know what clinical trials were. So that was a big deal there. When you go to the next slide, I think I'm wrapping up, but what is ambiguous loss? And I shared this last time when I introduced this session for this week. Ambiguous loss, if you could be so kind to take a picture, because this is actually what we're going through even during the COVID when we lost a loved one. It's the physical body is absent or changed, but psychologically the person is still present to the family and loved ones. So basically that person is actually lost, meaning that the lost soldier where the person is no longer there, and you never saw them die. Or the COVID-19 loss where that person may have gone into the hospital and you've seen them go in and they're gone. That's it. So you really never had what we consider a closure. The other portion, and this is what we see in dementia patients, the body is present, so you see the person, but psychologically the person has changed or no longer that person. For me, in that situation, and you'll hear our guest who's going to talk a little bit about it, my grandmother, I mean, I'm like, wow, I moved to Arizona, and then I had a grandmother. I go back to Michigan several months later to find out I don't have the same grandmother. That's what that ambiguous loss is. The person is no longer there. And remember, dementia is a progressive disease, so she's not going to return back to her same person. She's going to decrease and decline as time goes on. So there are two different types. One where the person is physically gone, but you remember them, and one psychologically gone. There's basically this non-traditional grief and loss, if you will. Changes can be confusing, because it can be, as you can see in most cases. Dementia has become confusing. Also, it cannot be cured or fixed. You have to adapt to it. The next slide is the adaptation. So how to address it? There's books on there, but I really love this book and highly recommend it. And if you are not working with or dealing with a person with dementia, don't go to the next slide yet, but there's another one that I'm going to share with you that Pauline Boss is a colleague of mine who's written a book. What she says is name the problem. What is it? You have to live up to what that issue is. And so for those who may have had a family member who had dementia and you realize, like in my case, that's not my grandmother anymore, then I had to name that problem. I had to, as ambiguous loss basically helped me to name the experience. I realized it was a partial loss. The barrier of coping and grieving was not the same as Kubler stages. You know, those Kubler, it was totally different. We had to figure out that but-and situation. And that but-and was basically, my grandmother's no longer my grandmother, but she's the person that I now see as another person. And I learned how to deal with it. You have to remember, if you don't do that for yourself, you won't cope and you go down. And remember those brain cells that I shared with you earlier? You're going to kill your brain cells off too, trying to figure it out. We do that with our children too, don't we? Okay. No right answer, and trusting things will work itself out no matter what. The next one is what I really want you to look at. Next slide. This is a new book. So Pauline Boss said, you know what? If I can create or write a book on dementia, I can write a book on the pandemic. So this book basically is ambiguous loss can also come from grief not involving death directly or the disruption of norms and social networks that the pandemic brought on. So I have began looking at this book, and this book basically tells us, how do we put closure to losing our loved ones? This is where that grief and loss, we can't, because we remember that person is there. I know many of us have actually attended a funeral or recognized that a person was here one day and they're gone the next, but how do we develop closure? Beyond reading a book, having we always talk about when we're exercising, having an accountability partner, the same thing, having an accountability or a spiritual partner, having to talk to them and being very transparent. And I do that with my nephew. He lost his grandmother during the pandemic. And I said, call me no matter what. And one time he called me and screamed. And I said, what's wrong? He said, you told me to call you no matter what. I said, oh, okay. So he just wanted to scream. So you have to have that. The other thing you want to be able to do is say, hey, I have a support group. And that's something that we're hoping to do this fall at Antioch, to just try to look what kind of support group and support we can offer. Ambiguous loss not only talks about the death, but also we look at it in the United States, Black Americans endure ongoing ambiguous loss stretching from enslavement to today's police violence. We just lost someone recently, 60 shots, and then were handcuffed. That's a loss there. We also said that many people experience the kind of grief that is durable affects the climate change, and we acknowledge that as well. So this book, this is no disclosure, but it's been very helpful, and it recognizes that grief and loss come in so many different forms, and we have to recognize it and know that we must be healthy with where we are. As I wrap up, I'll go to the last slide, I believe. These are some of the information. Feel free to take a picture. This will also be on our video, if you will, and we can play it back. Hover over each of these areas. You'll see there's a way to sign up for newsletter. There's also, for those who are in-house, there's documents in the back that if you feel free to get them. Facebook's research studies, I've talked about that, how you can get involved, appointments, and also finding different classes, some of them in which I teach, that you may want to be interested in involving. without further ado, I believe Dr. Pullins have a guest that's going to come in and share his story.
Yeah, but before we do that, let's give Dr. Allen a hand. That's a lot of information in a short period of time, and we could have spent a little bit more time, but we want to kind of give you also a personal flavor to this. So tonight we're kind of doing all in-house people here today because we are blessed to have such a population of people. But many of you know our own second assistant, Elder Hal Smith, and some years back, I can't remember how many years now his father has passed away, but he did have dementia. And so we saw him, the role he took in being a caregiver for his dad. And he brought him into the services sometimes for those who were here during that time. So what we're going to do is actually bring Elder Hal Smith time. So what we're doing is virtually from home. And good evening, Elder. Can you hear us?
Yes, I can. Can you hear me?
I can hear and see you.
Very
Well,
good.
welcome tonight. We didn't really set a particular question lineup for you, but if you can just kind of tell us, give us the journey, even starting from the beginning with Dad and how you first noticed something was going on and kind of how things progressed.
Well, it mainly started and became very noticeable to me after my mother passed in 2012, because then we began to, spend a lot more time with my father because my mother and father were inseparable. And so now he was in the home by himself, and we had siblings that lived nearby, but because of that change in his life, we began to spend more time and begin to see that he was not the same father that we knew. And, it became apparent through conversation with my siblings that he had been having memory challenges, and that were sort of being masked by mom while she was around. But now that she wasn't there to sort of cover for him, we had to deal with those um, challenges firsthand. And so that in itself became, very eye opening about how to deal with that and how to sort of help deal with him to sort of embrace the changes that were sort of happening in his life. And so we did that, but some things began to happen as it related to his health. And we needed to step up our care and our um, I'll say our care of him, and even the awareness that we had, because he was old school, and he didn't want anybody to actually know some of the struggles that he had. Um, and so when we began to sort of find those out, he would still try to sort of cover them up. But he had an episode and had a seizure probably in 2013 or 2014 that um, sort of accentuated uh, the, the struggles that he was going through, the memory losses and dealing with dementia. It escalated and became evident that he was really dealing with a cognitive and memory issues that was really hard for us to deal with. And so, thankfully, I got to put this plug in there. Thankfully for the summer health series, there was so much that I was made aware of as it related to dementia, and so I was able to talk with Dr. Allen and be able to get him an assessment and begin to find out exactly what was going on and the help that he would need and the ways that we could sort of help him in his situation. And so, one of the benefits in all this is my father was a planner. So even early on, he had laid out his his plan, his will, and put me over as the medical power of attorney, and my sister was the financial, but I was the medical power of attorney. So the things related to his health, hit me first, and we talked about it as a family, as we moved forward. So having recognized after the assessment he got that it was good for him to be aware and treated as somebody who has dementia, because it did come out that that's what we were dealing with. And so, we made the family aware of that and begin to sort of treat him and deal with him with that understanding. And so even as it related to that, we um, knew that he needed more care. He couldn't stay at home by himself. He needed to be in a place where he could be watched over and cared for. And that in itself became a very difficult challenge to um, put him in a facility. The family was sort of divided on that. We some thought we could do it ourselves, and others, it was just a whole nother family dynamic. But in that, I did seek counsel. I'm like, Lord, what do I do? I saw my pastor, and my pastor said, well, talk to some others that have parents have been through the same thing. And the reality is, it's very difficult to take that on if you're not equipped to do it. And so, thankfully, my father had full VA benefits that was able to make sure that he was in a facility. So we were able to do that. And I felt comfortable doing that because I knew he was getting the good care. And so then it just became incumbent upon us as a family to make sure that we cycled in and visited him on a regular basis. And so that's what we did. And even in the power of attorney, he wanted to be in a facility. He didn't want family to have to take care of him. And so that added some comfort to it as we had to deal with him, and in the dementia stage. And even as Dr. Allen had talked about, dealing with the ambiguous loss was uh, something that individually, we had to deal with, because we knew our father as a man who had a very sharp memory. Loved to spend time with his family and talking about the word. There's scriptures and verses that he just remembered and that were very much who he was. So we enjoyed that. We enjoyed that time with him. But as we're dealing with his memory loss, and he's no longer the same person, it was a challenge um, dealing with that new person. There was times when he would smile and laugh, and I loved to hear the conversations that we had with each other in his presence. And then there were times when he was dealing with the hospital staff that he would become angry and upset. And I'm thankful that he trusted me enough to be a calming and soothing uh, personality for him. Because when I would come around, if he was upset before I got there, when I got there, he was able to sort of calm down and relax and receive the treatment and the care that the staff was providing for him. So it was uh, a very difficult challenge at times. Sometimes it was hard to get up and go and provide this service, but I know he needed it. And the family was a support and encouragement to each other. And of course, again, I have to say that the armed and equipped with the information that Dr. Allen is so not only privy to, but it's so much of who she is. It was a tremendous blessing to receive it and be able to pass it on to my family, as I saw that they needed it as well.
So, Elder, thank you for sharing that personal journey. What was the time frame um, between the time your mother passed and he passed?
My mother passed in 2012, and he passed in 2017.
So that was a 5 year. You said mom had covered for him, but looking back, do you see signs that you guys kind of maybe just ignored while mom was alive? And what was those things that you really didn't mention or pick up on?
Well, the things that sort of slid by us was, if he would be talking, he would sort of uh, forget where he was going to go in his conversation, and he would sort of laugh it off, and and go another way and begin to start up another conversation. With hindsight, those are the kind of things that we saw that he was doing. And mom would sort of chime in at those times and sort of continue the conversation, or pick up and move it in the direction that he was going in the first place, and he would sort of chime in afterwards. But then also there was instances where he was um, out driving, and I found out about this afterwards, because I have a sister who lived in closer proximity and was aware of a lot more of it than I was. But he would forget where he was going, and some of the things that he was doing. He probably lost his wallet, misplaced his wallet about 4 or 5 times in a period of maybe about a year, and close uh, calls with accidents. So there were times when he probably should have been relieved of driving earlier than he did.
The issue that I deal with a lot, particularly when I have adult children bringing their parents in, is the loss of independence. And so
Yes.
the keys are a big issue. And so, how did you deal with that in that situation?
You know what? It sort of worked itself out, because once he had a seizure, or what we thought was a stroke, but ended up being some type of seizure. His condition was such that he could not drive any longer. So we didn't have to sort of worry about taking the keys from him. We thought that if he would have came out of the hospital and would have went back to some form of normalcy, we would have had to take the keys, but that never developed where he was in a position where he could drive. He was always, after that, sort of being driven to places until he was actually um, uh, taken into a nursing home in 2014, 2015, 2015.
So we want to leave some time for some questions and answers. I guess my last question, or would ask if you could speak to those that are here, maybe those that are in virtual land. What advice would you give to those who are maybe dealing with this issue right now, dealing with a family member as an uncle, aunt, or mother or father? What if, after what you've been through, what will be the advice that you would give to them?
Well, I guess the advice that I would give to them is, uh, try not to do it alone. If you have family members, or a community around you that can assist you in this journey, do that. Receive all the help, and try to get as much knowledge as you can dealing with it, because it's already going to be difficult not knowing what you don't know. But if you can find out more information in ways that you can understand what's going on at various stages in the process for them, I think that would be a tremendous blessing. And then also, even as was spoken about by Dr. Allen, still try to find ways where you can pull back and get some rest yourself, and get yourself rejuvenated. Because if you try to take it on full force without taking care of yourself, you're going to wear yourself out quicker and sooner. So those are the pieces of advice that I would give those that are actually going through it, even now.
Well, thank you, Elder Hal Smith. I think that that gave a personal face to the disease process that we're talking about. And obviously, since you're among us, if there's people that have questions, they can always pull you to the side and also get your input. So thank you for joining us tonight.
Okay, thank you. I appreciate the opportunity to share. And you know what, Doc, I got to say it again. The health series has been a blessing to my household in so many different ways. So for the summer health series, and you and Dr. Allen and the pastor allowing it to be so, it just brings a blessing to us in so many different ways. So thank you guys so much.
Appreciate it, sir. Appreciate it. Open it up to questions. I know my phone was already buzzing. People are texting me questions here, so I'm gonna try to get one off while you guys come up with the question. So it says, "Hi, Dr. Pullins. Please ask for me. My husband had dementia and would repeat himself quite often. He also didn't take good care of his teeth. So is the plaque you spoke about come from your teeth? And if not, where does the blockage come from?" So I think I'll let you answer this, Dr. Allen. I can chime in if you want me to. But this, I think what she's asking, when you were asking about the amyloid and tau plaque, she's asking whether this comes from the teeth. And if not, where does the blockages come from?
So you can actually continue what I'm getting ready to say. Most people will say, oh, plaque come from the cardiac, because remember you talk about the plaque, they talk about the teeth, and then they talk about brain. So plaque can be built up in various areas. And in this case, we're referring to the brain amyloid beta plaque, which is actually built up in the brain cells, and tau or tangles, we call them, that is developed in the brain cells. And as I shared, as we talk about this, and it goes even deeper, but the plaques and tangles, and any plaques, it's because of what we do, what we eat, how we live, who we are, our DNA, et cetera. So it's built up more in our brains.
Yeah, and the answer is not the plaque on your teeth. Yeah, that's totally different material.
And that's a good question.
Yeah,
'Cause we get that. Yeah, we get that a lot.
Yep.
So.
It's a good question.
Are there any questions?
Yes, sir. Elder Brother Cook. And I'll repeat his question, so you can have a mic. Don't worry about it. I can hear him. I'll repeat it. Go ahead.
Two questions, really. Trazodone, they use that for sleep too, correct?
Yes, that's correct.
How does that affect you on the long term?
So trazodone is something we use all the time, and there's really no concerns about long-term use of trazodone, which is a sleep aid. Now, some of the other medications that are used for sleep, like Ambien, Lunesta, those medications aren't necessarily meant to be used long-term, although they are quite often. But trazodone, there's really no long-term problems with that. That medication is also an old-school antidepressant, but we don't use it for depression anymore. But it is used for sleep. Yes. Yes. Oh. Yeah.
What do you feel about young men and women that's involved in sports and they get concussions or old term get the bell rung? Does that long term for them? What they maybe develop all kind of later on down the line?
Yeah, so repetitive head trauma is not good, period. But yes, there is, you heard probably of CTE, which can cause behavioral changes and things like that. So yeah, repetitive head trauma is never a good thing long term. I don't know if you want to add to
Yeah, and
that.
also remember, we utilize dementia and Alzheimer's interchangeably. So when you mention Alzheimer's, they may not be detected as having Alzheimer's. They may have some form of dementia. And if you go to that third or fourth slide that talked about the different characteristics of dementia, you'll notice that if they exhibit at least 3 to 4 of those, especially on the onset, you probably would notice that they may form some type of dementia. Will Smith played a movie and talked about that. Muhammad Ali, who now, obviously had his whole center here, and he was into sports, and then the list goes on. Concussion, as you heard that movie. There are things that we see, and actually, many people probably know that in our center, we have a lot of celebrities or a lot of sports figures that come in. They may not come in during the daytime, but they come in, they're seen. We're an Alzheimer's and Dementia Center. They have the characteristics of those dementia forms. So that's a very good question. So yeah, they are forms of some form of dementia, or maybe. Who's that? Mood swings, yeah. It depends on, again, the diagnosis. So you don't know it. They have to go through the whole workup of the diagnosis. And yeah, that's why I said mood, personality, and behavior was one of those characteristics.
Yes, go
Hey,
ahead.
Doc, I have basically a great concern for myself, being a spinal cord patient, what is it, incomplete quadriplegic, with fusions so close to my brainstem. I have neuropathy damage, and I'm on a antidepressant medication. As I get older, I notice shifts, in my body from nerve, from hands, feet, and sometimes even my wife was telling me, sometimes I forget things. And so being a spinal cord patient and having those type of injuries, am I more susceptible of coming up with Alzheimer's or dementia quicker based on people that don't have those type of conditions?
I'm not aware of having issues with your nerves increasing your risk of having dementia itself. Like I said, I always tell patients you can have more than one issue going on, but I don't know that there's a connection that's with those kind of issues. That's a neurological. So dementia, nerve issues are all in the nervous system, but that doesn't mean one causes the other. So I don't know that there's any connection between that.
And we do have several patients that will come in that have a lot of the things that you've just mentioned. And what we do is we tell them not to say no. We want you to come in. We want to find out. But when we do the workup, if you remember the scans that I shared with you, if the scans are not depicting that there's a possibility of a cognitive or neurological concerns, we tell you that like Dr. Pullen said, that's something else, and then we refer you there. Again, you have to focus on we focus primarily, we always say the head up and what's going on here. But there are certain things that may be going physically with you that may not be depicted in that area.
Yeah, and there's tests like she was talking about the mini mental status exam, which is a test your primary care doctor can do to see, and it's just a quick test to look and see if there's any deficits in certain cognitive fields, and if there's not, then they kind of can stop there if it's not below a certain number, and that's an easy way of getting a quick check. Yes, Sister Taylor.
My mother had Alzheimer, and but I'm going to deal with the seniors period, because when we're dealing with Alzheimer and different things that are coming up in our parents' life, we need to find out about their financial position, insurance, and everything else. So whenever these things like this happen, you'll have an idea of what you can do and how to go about it. And just don't take it for granted that everything is in place. You can't just take things for granted, because it don't work that way. You have to get involved in your parents' lives. And your senior people that you're dealing with, you have to find out these things in order to help them. And Alzheimer, my niece in Baltimore, she had a stroke, that vascular
dementia.
Yes, and she's, I think she's about 10 years younger than I am. And she had a stroke and took her right into Alzheimer. She called me and was talking about things. Her mother had died early that year, and she was talking about me, all these things that I could come and get her. I said, Diane, I'm not in Baltimore, but these things happen. But even young people need to get their financial situation and things in order. Medical power attorney, financial power attorney, all the things, because you don't know what could happen to you in your stage of life. Just because you're healthy today, that don't mean you're going to be healthy tomorrow.
Yeah, I agree. And I think, you're going into our next session, which is no, that's all right, which is actually financial planning. I appreciate that. And I think just to put a plug into that, you're correct. Most people will say, why? I love Elder Smith. His story was just it brought us to home, because, my family members were angry with me when I placed my grandmother. And why would you do that? And I said, because she told me to. She said, live your life and don't allow me to interrupt whatever you're doing. And so I placed her. So not only to not go into the financial piece, but know what your family members like. Dislike. My mother cannot stand it. She just recently had surgery. She can't stand when I flew there. I said, where's your paperwork? Where's the life insurance policy? I forgot what we put it. And she's like, oh my God, really? I said, yes. Because I'm not going to sit here and figure out where it is if something should happen. When I travel, I call people, hey, I'm going here, this is where I'm at, I'm stuck here, because you don't know. So thank you for going into our next session. I appreciate it.
And I think with that, we'll do one last question, so we are out of time. And then after we answer this, I'll have you go ahead and maybe talk about next week's before we. Do we have a line?
Yeah, we'll do that
we'll
one
do
and then the one in
Sister
line.
Jackie, and then we will do the online question, and then we'll start having our final words. Yes,
Thank you.
Sister Jackie.
Okay, I recently had a test done. They took some blood because I had mentioned to my doctor that my mother was experiencing some Alzheimer's, and I think she took about 11 tubes of blood for me. That's normal, correct? Is it?
Well, it probably was, there are some markers, but, we talked about there's different types of reason why people have dementia, so you want to rule out other things. So it's probably a battery of tests to rule out other things that can cause, memory issues, not just dementia, but just memory issues.
And I'll also throw in there that what they do is, again, they rule out, they look to see what's happening. And most commonly, not for you, but in older age population, 65 and older, they may have urinary tract infection, which cause short-term memory cognitive issues. They also have what is called delirium, which is a short-term cognitive issue that may be caused by some patients who've had surgery and anesthesia or certain medications that have caused them to actually change immediately. So again, one of the plugins, and thank you for sharing this, I don't want everybody to walk out and say, oh, I got dementia or somebody, no, I don't want you to. What I want you to do is go back, look at the video, and look at what we said. But there are cases, as a matter of fact, I'm working on a study at Banner now, at post-op delirium, and we're determining whether it's post-op delirium or did they have dementia. So there are different things that we do detect. And like Dr. Pullen say, which I'm sure he does it too, is he does a workup. And so it's like trying to figure out everything's negative, the thyroid levels are good, the urine is good, and so therefore it has to be cognitive. And then they do that assessment, which is the test he pointed out.
Yeah, and last thing I'll add to that, genetic testing, I never do genetic testing. I send the patients to a genetic counselor because when the repercussions and the emotional responses and all stuff that comes with genetic testing, I don't order them. So if a patient's at risk or they want to know, we send them to a genetic counselor who can actually do the tests and give you appropriate counsel on what that means. So I'm not sure what they ran. We can talk offline, but that would be something that if something does come back, I would, rather than just sticking with your primary care, I would go to a genetic counselor to see, well, what does that mean for me? What does it mean for my children? That would be my recommendation.
And by the way, that's another topic we'll be talking about.
Yeah, and we will be talking about genealogy coming up.
And also, she mentioned something about inflammation that can be in your brain, and some supplements that she gave me that I can take to possibly help the Alzheimer's or the memory loss.
Yeah,
Well,
so she
help-
probably did a CRP or
Yeah.
a SED rate, which are these markers that look for inflammation, because there is a connection between inflammation and blood vessel disease. And so that's probably what.
And I want to put a plug in, not to help Alzheimer's, and it's just to detect whether there's some inflammation, to decrease the inflammation in your brain so that they can continue to follow up, determine what it is. Because I don't want to be, to say it's helping, but thank you.
And we have one last question online. If Minister Baker can give us what that is.
All right, can you hear me?
We can hear you.
Okay, it says, just as most depression meds can cause suicidal thoughts, is it possible for any of these drugs to actually have side effects that cause memory loss as well? And I think she's referring to the list of medications that Dr. Allen was going through earlier in the slide.
So the medications that I refer to, which again are the cholinesterase inhibitors, they actually will help the acetylcholine to help memory stay. And that's the medications that we work with. The other medications are actually directly used for patients individually. So if a family member or the patient exhibits some type of psychiatric, which is bipolar, schizophrenia, or depression, we give them the medication to hopefully slow or stop that depression and schizophrenia. So those are the medications we do to counteract what's happening with the patient. But I've never known them to actually cause it. And if they do, that can be an adverse effect on that individual, and then they would have to follow up with their primary care provider or someone else. So, Dr. Pullen.
Yeah, so when there's studies, there's a difference between causation and correlation, meaning that sometimes you may see they'll do a study on some medication, and they'll find that some of those patients have dementia, but they can't really say for sure was that medication, because if you're just looking at general population, you're always going to have some people that have dementia no matter what they do. But there are some medications, like some of the cholesterol medications, I think the statins, there's been some patients who they said that may be some relation with dementia, but when you look at the risk of developing cardiovascular disease, which is one of the #1 killers in the United States, the benefit outweighs those risks. And so you always have to look at the big picture and not get stuck on one. Well, that's going to cause me. Well, yeah, maybe, but you may also have a heart attack and die. So you have to kind of look in, and that's why you need a physician to look at stuff. So when you see stuff online, you have questions, take it to your physician and don't just try to become Google doctor, because a lot of times you don't have the information to know how to interpret that information. So you want to always take that to your primary care doctor and have them explain what this is saying. A lot of times when you watch news programs, they'll have this one-liner about some new medication, or this causes this, and you don't know anything about it. It's a small study with maybe 100 people, and it's really not significant in the scientific world. We'll say, well, that doesn't have enough, we call power, which means that there's a certain number of people that had to be treated and all these different things that tells whether a study is actually legitimate or not. So you have to be careful on even what you hear on nightly news. So that being said, Dr. Allen, if you want to talk about next week, and then after that we can bring Dr. Logan to close us tonight.
Absolutely. If we can go to that slide, or our original slide with our flyer, or just talk a little bit about some of the things. While we're getting that done, how are you all enjoying the Summer Health Series? You really about some of the things. While we're getting that done, how are you all enjoying the Summer Health Series? You really, yeah. So, lots of information, lots of topics that we've shared. I don't know if the slide's going to come up, but I know some of the, oh, there we go, okay. So some of the areas that we've talked about already, I think we are looking at emergency preparedness. I'm excited for that one. Emergency preparedness, Brother Dunn is going to talk about how do we prepare for emergency. When he introduced it, he approached me, he says, I want to talk about this because everyone calls 911 for everything. And we really want to make sure that they're prepared appropriately for that. So we'll have him on next week to talk about that. I think it's already been spoken on financial planning and investments. I think we have a phenomenal individual that's going to come and talk about that. I hope the house is packed on that day because we do need to be mindful. People think you have to be wealthy to have financial planning. You don't. All you're trying to do is if you got a quarter in the house, you want to let them know where that quarter is if something happens, right? I say that all the time. My niece knows, and it's been known, to get everything, and she walks around the house, is that mine? Yep, but please let me live before you take it. And then, and then the last thing is the genealogy, and again, we'll be talking about that and our family history. And I love this person who's going to come and talk about that because she's going to focus primarily on not where you come from, but also how health impacts where you've come from, and we've spoken about that as well. So I'm excited for the topics. I know that I know you are because you're here, and so we appreciate it. As always, our pastor's going to come up, and as he's making his way up, I want to make sure that everyone has a raffle ticket. We have our raffled gift tonight, as always, and we hope that you enjoyed it. Thank you.
All I can say is wow. In our culture, is that we only value things if it costs us something. But information is always important. And, I read a lot about different diseases, different medicines, but what's missing is I'm not able to do a comparative analysis. We have experts that can give us a comparative with other treatments, other medicines that help us to make better choices. And then the last thing I want to share is this. It's important that you realize that as you get older, there are going to be a lot of things that you're going to have to deal with. And getting information while you're younger helps you to prepare better when you're older. And so I want you to be an advocate for the Summer Health Series. Let your family members know, let your friends know. If they can't come here physically, at least have them watch online. I spoke with a pastor in a small town in Alabama today, and I told him how to download the app and how to listen to the health series because his congregation is facing fear of the pandemic and trying to help Dr. Poland's presentation. I told him, watch that. He can use that to inform his people, and informed people make better decisions. I got ahead of myself here. I want you to give a hand to Dr. Allen, Dr. Pullins, for just an awesome presentation on tonight. I don't care what you say, as you age, you are concerned about these things. And I would rather have information so that I'm not worrying over something that's not even an issue. Information can help you to reduce your stress level about the changes that are happening in your life. How many of you realize that you're changing? You're not just remaining the same. And so the Summer Health Series is helping us to adjust to those changes in a balanced way. And I think that's very, very important. Let's give our presenters another hand. Also, as you know, next week is going to be a big week for our youth department. The summer, not summer help, the Antioch is going to be having their camp. Antioch Academy is going to be having their camp. And it's going to be from Monday through Thursday. I want to thank you all for sponsoring some of the larger families so that all of our children can have a wonderful time. And then in the weekend, we're going to be having a big youth celebration. And so we want you to come out and support that. Just look online, it's being advertised there, so I don't need to go into all the details. But it's very important for our young people to come together in our community so that they can value the church. I think that's very important. When church isn't an important issue in our young people's lives, then they tend to not want to be a part of the church. And that's something that we cannot afford to have happen. Yes. Yes, tonight we had our first, I won't say our first of the year, our first White Care meeting of the year. And, White Care is our program where we minister to some of our young girls to ensure that they know how to carry themselves, they know how to act appropriately, they have good manners, and they know how to present themselves. How many of you know that's important? Because a lot of times when you go for employment, people are going to look at how you carry yourself. And we used to say sometimes the first impression is a lasting impression. And so we want to support that when they have their next class. If you have children, what's the age category? If you have girls 5 to 11, we want you to bring them out so that they can get the training that they need. We're not trying to replace their parents. We're trying to come alongside the parent so that they can assist them in raising mannerable, well-informed young women. We're standing. I just say to you, there are many among us that are sick and going through different surgeries. I just ask that you remember them in prayer. If you were sick, if you were going through a tough time, you would want people to pray for you. So do that for them. Let us bow. Lord Jesus, we are just so grateful for all that you have done and all that you're going to do. You have greatly favored us by putting among us people that are able to inform us concerning our health and the health of others. Oh God, we are grateful, oh God, that they are willing to take their time. You give up their time to be able to minister to us and to help us to be knowledgeable so that even when we go to our physicians, we will understand what they're saying and be able to act in the appropriate way. Father, we are asking you on tonight, be with those who are sick and shut in. Lay your healing hand upon them. Help them to know, oh God, that they are not alone, that we remember them and that we are praying for them and that we are concerned about them. And Lord, we just pray that you would help us, oh God, to respect the fact that the pandemic has not left. It's still here. Help us to protect ourselves and help us in doing so to protect others. Now, Lord, even as we leave this place on tonight, watch over us and protect us. Allow us to arrive at our homes safely and without incident, finding our homes as we left them. We ask this now in the precious name of Jesus. And all of the people of God said, Amen. God bless. Greet your neighbor. Let them know that you love them with the love of Christ. God bless you. Oh, yes, and Dr. Allen is going to conduct our raffle. If you have a raffle ticket,